سمارت سیتی ئەبی هۆسپیتاڵ لە سەرڕوبەری 6,000 مەتر دووجا بنیاد نراوە کە سەلاتی سەرەکی نەخۆشخانەکە بە تەنها 1800 شارێکی هەزارێکدا پەرەیکرد کە پێکاتە گشتیەکەی بریتیەدا نەخۆشخانە، پۆلیکلینیک، وەرگەکان، مۆدیلی تایبەت، ڕێستۆرانت، پارکە و بەخشی ئۆتۆبێت. تەلاری سەرەکی سمارت سیتی ئەبی هۆسپیتاڵ پێکهاتووە لە 12 هۆم کە 120 بێدی نەخۆش، 16 هۆڵی نەشتەرگەری پێشکەوتوو زیاتر لە 30 نۆرینگەی پزیشکی پسپۆڕ لەخۆ دەگرێت. 5 نهۆمی تەواو تایبەت بەوە بەمانەوە و پشوودانی نەخۆش کە لە هەر نهۆمێکدا پزیشک پەرستاری پێشەگرێت بە شێوازی 24 کاتژمێری ئامادە. ئێمە شانازی بە ئەبینکردنی ئەبوونیان یەکەی تیشک لە سمارت سیتی ئەربیل هۆسپیتاڵ پێکهاوتاترین بەشە لەسەر ئاستی ناوچەکە و جیهان وەک پێشەنگێکی دەستنیشانکردنی وەتی نەخۆشی دەرەکرد. سیستمی MRI-مان بۆ بەخشەسازی پێشکەوتووی مێشک و مەسوولەکانی دڵداگیر کردووە کە هاوتایی ئەمە پێشترینی CMR لەگەڵ تەکنەلۆژیای مایەمەتین دەخۆت کە تۆ ئاماژکردنی وەتی T1 T2 PCV هەیە. ئاستێکی دەکمەنە لە ڕوودەکانی دیاریکردنی جۆری شانەکانی بەسەکەی دڵ. تیشکی ناوچەکە ئێمە لە تیشکی ناوچی پێشەنگ وەک هێزێکی دەستنیشانکردن و ئاپۆچەرەسەر دەستنیشانکردن بە بەکارهێنانی شانەی سێتی بۆ وێنەگری فەرمانی بە کۆڵێکی زۆربەر بۆ چارەسەرکردن ئێمە ناوەندێکی سەرنجین چارەسەریۆری تیشکدار بۆ پێکەنجێکی سەرەکی و گرێشەکەیەکانی تر هەروەها چارەسەری لوتیشۆ بۆ شەکەندەی پۆستال پۆسپۆڕی پێشکەوتووی بۆ جەمال لە بۆری کۆتا وێنەگری تەکنەلۆژیای ئارمان بۆ نەخۆشیەکانی خوێندنەری کاتی بە ناوی AIFR ناساندوو کە ڕێگادا بە هەڵسەنگاندنی فەرمانی زۆر و بۆ دیاریکردنی ئایا نەخۆش پێویستی بە نەشتەرگەری بۆڕی فەرمانی کاتیەکان یاخود نا. لە ژووری نەشتەرگەریدا سیستمی ڕێگەزی پێواتر کە نەشتەرگەریەکانی دابردنی پێمێش وەرگرتنی نمونە و نەشتەرگەریەکانی پڕڕێ کرد بە شێوازێکی زۆربەت و بە کەشتی مەترسی ئەنجام ئەمە بەڵگەشتیکە بە ئەمەری دیسی AR بۆ چێگیرکردنی بڕڕەکان مایکرۆسکۆپی ڕۆبۆتیکی بۆ 2025 بۆ نەشتەرگەریە مەژەسیدارەکانی وەکو لوتوجێ گیرفانەکانی لوت بنکەی کاسێک سەر و چەندین نەشتەرگەری کرد. ئێمە تاکە ناوەندی لە عراقی بە پشتنی نمونەی گرێنی پاوێکان بە بەکارهێنانی جاماکۆپ ئەلها ڕێدەی بۆ نەشتەرگەریەکانی مەملەکەت ئەنجام بدرێت. نهۆمی تایبەتی منداڵان جیهانێک لە ئەرامی چاودێری چونکە منداڵەکانتان شایان باشترینن نهۆمێکی تەواو بۆ ئەوەکەتان ژینگەی ئەم نهۆمە بەڕەنگی پێشوەی ڕازێکراوەتەوە تا ترس و دۆڕاوچوە لای منداڵەکانتان بکرێت. بەرگەبەشتی چاودێریی منداڵان PICU لە هەولێر دابینکردنی چاودێریەک بۆ ئەو منداڵانی پێویستیان بە چاودێری چڕی بەردەوام هەیە. پێشکەوتووترین بەشی منداڵانی ناچار NICU ئامادەکراو بە ئامێری پێشکەوتووی وەک سپایرەڵ و هەناسەدانی دەستێت بۆ ئەو منداڵان پێشبڕکێکەوە لەدایکەوە. کەوتنی خێرای منداڵان ئەسکارێکی بەزیشی پسپۆڕ شێوازی کاتژمێری لە ئارەشدان بۆ حاڵەتە کوتوەکان خزمەتگوزاریەکانی دیکەی منداڵان ژووری تایبەت بە ئامێری کاتبەسەرانی نەشتەرگەری قەزای منداڵان شۆڕیاری هەوانەوە ئەوەها بۆ بە شێوازێکی گەمنانە و بێئازار سەرکردنیەکە پزیشکیە سەرچەکە یەکەی چاودێری بەشێکی دەرمەنی تایبەت تەنها بە نەخۆشخانەی ئێمە بەردەستە. سنتەری مەموت و دایرۆ یەکەم گەورەترین سنتەر لەسەر ئاستی ناوچەکە بۆ دەستنیشانکردنی مەمەت لە ژێر چاودێری
ئەوەی زەولایە گەڕێتەوە
فریاکەوتنی خێرا و کلینی تایبەت یەکەم فریاکەوتنی 24 کاتژمێری لەگەڵدایان ئۆتۆپێلی فریاکەوتنی پێشکەوتووی سەردەم کە کەمپی ماوەدا دەکەنە دووترین ناوچە سووریەکان
سورانە نردوێن
سنتەری جوانکاری داخلی وەرگوت دەرمانخانەی پێشکەوتوو بە ستانداردی جیهانی ئامادەکاریش لە Smart City Admin Hospital Puglia. كمان سمارت سيتي أدمين هوسبيتال وكرم 20 بزيشتان من الخيجاني فالدوام دي 20 بزيشتان وواقعيين هولي وكنوي رقايدون من خوشكانا سمارت سيتي أدمين هوسبيتال مدوزاري موتلي ندوتي في الشرق فنقوشو هاوتا مكانينا فدادين بزين شوي ما نقول كايفت هاتشيروي هوتيل الراكيكان وأو نقوشو هاوتا ماني لا دروي هريب يعني دروي ولاط وسردانا نخوشانا كمان بيريتا وقتاریانی باشد پزشکی‌کان لرهی خشکتن سیمیناره و تزیین هایی کنفرانسی داشته بود. توانی دولت پروژه تدریسی شاید پزشکی هویت نیکمو دولتی نوانی اونجوری لنفسه افشار پزشکی زیادتر لچه پزشکی از ورزشیان لفوردی و پشتیمون چهار سرگلی دادیم که کتشر تنها لپیشوتی موافقی چند دارونیان. سمارت سیتی أدمین هوسبیتال متمرکز شماسیه. سمارت سيتي أدمين هوسبيتال إكرام نرجو الشكر والترشيح أدمين هوسبيتال رايفا ولا تدرس يكو سمارت سيتي رايفا سيكينا وبشير يكما يكو لكن أو خصمتي كنت شارع فوزانها وإنك ناوي شيء الفاز سمارت سيتي أدمين هوسبيتال
Hello. Dengan dia.
One of the most important aspects of modern community surgery, which is navigation technology and integrated surgical innovation. The next presentation video will introduce advanced real-time navigation systems and will demonstrate how modern guidance technology is transforming the future of ENT and software surgery to improve precision, safety, and anatomical localization. Please enjoy the video.
Modern tools, a single millimeter can define the difference between precision and risk. Beyond guiding lies the power of intelligent navigation. The era of intelligent navigation has arrived. Think of it as a high-definition GPS for the human anatomy, powered by advanced electromagnetic fields. As the surgeon moves, the system follows. Every instrument is tracked in real time, synchronized perfectly with the patient's anatomy. This allows us to see around corners and navigate 8 structures with total control. With sub-millimeter accuracy and safety zone mapping, we minimize risk and maximize surgical outcomes. It is total visibility, even in the most complex cases. Whether it is functional sinus surgery, skull-based tumors, or revision cases, we provide the clarity to move forward with absolute confidence. The future of surgical excellence is here. Navigation system, now available in Smart City Herbal Hospital.
And now we will proceed with the scientific lecture titled Advantage and Disadvantage of Navigation. This session will discuss the clinical application and practical role of navigation-assisted surgery in modern ENT practice. It's my pleasure to invite Dr. Jman Mahmoud Aziz, the head of the ENT department at Smart City Urban Hospital, to deliver his presentation.
دعوة يوم بعد
know, the parameters are or even 1 millimeter miscarriage can lead to catastrophic or irreversible damage. So, navigation allows the cell to map boundaries in real time, especially in the pre-biopsy area.
تجوان
شو خسنا كذا
او هذا كمان
Personal Thomas Ray, called Civil Science G, many times. And that's why navigation stays as both the limit of the surgical instrument relation middle orbital wall. The middle orbital wall of the ramification is the one that is seen as a shape of the fetus. So shaking part of it can cause damage to the middle orbital muscles and also because the cranial double vision or orbital hematoma which can be blinded due to blood under the pressure or cause blood immediately. The smooth sinus, we know the relation of the smooth sinus to the vital structures here. Here, the navigation ensures that when the surgeon is experiencing the fungal garbage or the polyps from the nose, they do not inhibit vital functions. Surgical orientation by confirmation of the position. Here, navigation helps the surgeon to analyze the quality of the sinus. Especially when the landmarks are obscured by the qualities, tumors, or the scars from the previous patient, and also identify hidden sinus. Allow safe opening, especially the opening of the frontal sinus or facilities with the sinus. So completing the complete disease removal, here the radical removal of the disease. Surgeons are more confident to remove all disease tissues and open narrow drainage because they can see how close they are to the structure. And so that the tumor cells can completely remove the section of the tumor. Navigation shows that to complete the resection of the organ of the tumor to remove the cancer. Other important is surgical efficiency in the recognition normal spine and use of landmark using one landmark make the navigation more consistent for efficient and safe surgery. Of course, for the educational and training value, navigation allows training and less experienced surgeons to understand three-dimensional anatomy and to also a relationship between the endoscopic views and CT scan view. Like other machines or other procedures, also they have the disadvantage of these machines. First of all, it's increased cost and resources. Of course, in the equipment cost, we use extra materials and for the of this system, registering the patient's anatomy and verifying accuracy, which added about 5 to 15 minutes to the procedure. Other is image lag and inaccuracy. One of the most important steps in the navigation is to perfect registration, because if the registration process is imperfect, the instrument on the screen can be differed by the 1 to 2 millimeter from the actual anatomy of the patients. And another is a tissue shift. This disadvantage really happen in the brain surgery, not in the paranasal sinuses. When during the surgery, removal of the bone, drainage of the fluid, change in the intercranial pressures, it slightly affected the brain tissue to move slightly, to shift slightly, and this, since the navigation is based on the pre-operative CT scan, may produce some difference between them. Over-reliance and GPS dependence. It causes loss of the surgical skills. The greatest degree is that the surgeon may stop looking at the patient's actual anatomy and chart the screens blindly. The navigation is wrong with interpretations. That's why we must use this machine to helping us, not depend entirely on it. Also, like other machines, logistical and technical issues may occur. Head tracking optical system requires line of the side between the camera and the tracker which is placed behind the head of the patient, so an interruption lost the navigation. And also it needed the well-trained staff to do this operation. That's why there is guideline indication for the use of the navigations. There is American Academy of Otolaryngology recommended image guiding for what? For revision functional endoscopic sinus surgery, disease of the frontal sphenoid or posterior ethmoid sinus, which is close to the brain or optic, and patient with the low skull basis, basis parotid or asymmetry anatomy. Also in the case of the benign or the malignant sinus tumors. Thank you for listening.
And now we arrive at the highlight of today's scientific event, the live surgical session titled Navigation Guided Functional Endoscopic Sinus Surgery, Technology in Advanced Nasal Polyposis. This live demonstration will showcase the practical application of navigation-assisted functional endoscopic sinus surgery using advanced real-time image-guided technology. We are pleased to have Dr. Lana Abdelrazzaq Dabbagh as moderator, together with Dr. Mirish Aziz Rawandazi as co-moderator. Please welcome them to the stage. And please direct your attention to the screen, and the live surgical transmission will be starting soon. Hello, Dr. Hani. Thank you.
دكتور هي من جدة؟
جمنا نقول نعم جتنا من إيسا زمان.
الله يبارك أصحاب. بس ما يكتب دي.
هلا. دودا يعني.
هم الدود كده وكان هم زود كذا.
هو لازم يكمل.
استخدامه دكتور صفقة أنا هذا جزء أي بينو كم زمان
توصل دكتور يدي
والله
دكتور جدي مستر باشا
والله
باشا يسا
والله تسكريت
يدرون كم
shall we start? Shall we start? Victor Eric, you hear me? Victor Elana,
Bale.
do you hear me?
Yes, sir.
Yeah. Good afternoon. Thank you for Kurdistani Society for Otolaryngology, with cooperation with the Smart City Arbil Hospital for this nice event. For today, the live surgery, we have a case of chronic sinusitis with polyp. This is the sixth time of the case. I don't know if you see or not.
It's not so clear.
Not clear.
Just tell us, Dr. Hammond.
There is a pansinusitis of the case, and there is mild or severe circulation to the right side. We shall demonstrate the case from the left side. We demonstrate only the left side. Really, the case he has S-shaped deformity, pansinusitis, symptoms of Parkinson disease. Unfortunately, the case looks like he has adenoid disease, which now we examined the case, we found he has also adenoid. Unfortunate case, he neglected from the childhood. Now we are going to the endoscopic view. If you see the case, how it goes, and there is a set of deviation anteriorly in the left side. Posteriorly, there is a spur in the right side. We want to show you the demonstration on the left side because posteriorly it's wider and views very good. Okay. Do you hear me, Carolina?
Yes.
Yeah.
Start from here.
This is a septal, here is the anterior septal deviation. As you see, there is this one anterior tailmate.
Oh.
Yes. We prepared the case. The patient is head elevated to receive the venous congestion. And we put a part by concentrated adrenaline on both sides of the nose. Now we start. As you see here, it's a remnant of adenoid. You see, it's a second pushing. Malveris helmet, here part of the helmet. Now we remove the part, and I will show you the millimeters. As you see here, polypoidal millimeters.
Dr. Haven, have you heard me?
Yeah,
Dr. Haven?
yeah.
Would you mind to tell me the age of the patient? The age?
50 years. 48 years old man.
Oh.
Yeah.
Yes.
Yeah.
Among the audience, if you have any comment on the question,
As you see, the middle tailmate also, you see here, the middle tailmate is polypoidal. And this is a ethmoidal furrow. Here is the uncinate.
Dr. Haven, among the audience, there is a question. Have you heard me, Dr. Haven?
Yeah,
There is a question, please.
yeah.
Hello, Dr. Remy.
Vale.
Oh, okay, Dr. Remy.
Vale.
If you, when you started indicating the disease polyps, turbinates, and structures, please put the tip of the device on the structure.
Okay.
Okay?
Okay.
Because I got the initiation.
Okay. Now, as you see, this is the medial lattice and uncinate also polypoidal, as you see, and we will lateralize the inferior tailmate now. We will lateralize the inferior tailmate by out fracturing this posterior middle part of the inferior tailmate. And medialization of the middle tailmate to increase the area of our work in the middle meters. Out fracturing, as you see, the view is more clear. microfracturing of the middle cartilage from the base. Microfracturing at the base. You see? At the base of lamella. As you see, and then we took a biopsy from the polyp to know the number of eosinophilic count, or to differentiate between eosinophilic and non-eosinophilic. This patient most likely the patient is eosinophilic nasal polyp. And this piece for nasal biopsy to identify the number of eosinophils. Okay? You see, now we are going to probing the maxillary ostium, as you see here. Here is the maxillary. This moving part. Here is the lacrimal. This is called lacrimal duct. Here. Here's the lacrimal duct. This bony prominent. You hear me? The lacrimal duct. You want to remove the uncinate completely. The first, as you see, here is the movement of the uncinate. You see? You see?
Yes, yes.
We try to open the maxillary sinus. The safest instrument is backbiter, as you see. Frequently they do by sickle knife. Sickle knife has risk of injury to the orbital wall. There is the closing of the entrance, and we want to remove the middle part of the kidney. As you see here, 3 bars, usually 3 bars.
Dr. Heyman, have you heard me?
Yeah. This is the maxillary ostium. You see? You see?
Yeah. Dr. Heyman, have you heard me?
Yeah. I hear you.
Can you tell me what is the safest instrument for uncinate?
Backbiter. This one is a backbiter.
Thanks.
Yeah. And then, after removal of the middle part of the uncinate, we try to medialize the third part. As you see, there is a pus inside, or eosinophilic mucin inside the sinus. This is a maxillary sinus, and there is some polypoidal change. I don't know, you see or not. Here we will medialize the dominant part of the third part of the kidney, or medial wall of the maxilla. You see?
Yeah, it's clear.
I usually do this step by fluted instrument. Removal of the this area. Usually we will do by fluted. Yeah.
Dr. Heyman, can I ask a question? Dr. Heyman, have you heard me?
Yeah.
Dr. Heyman, at which, when you start to use the sensor, tell us the exact site of the uncinate or the antron.
Yes. Here is the lowest part of the uncinate, lowest part, and the medial part of the maxilla as part of the uncinate. This was third part of the uncinate process. the
Picture
middle,
here.
middle tooth head and this upper head.
I mean, the using of the sensor or the navigator system.
Yeah, okay. Yeah. This is the uncinate. This is uncinate. You see? Uncinate. This one uncinate. The ruminant part of the uncinate. Here is the posterior wall of the margin.
So the
You see?
yeah. This is the probe sensor, or it is molded with the endoscopy. With this.
You will see there is a probe. We can't do any instrument connect with the navigator. For example, this shaver, we can add a sensor on it, like this antenna, and this will be a sensor of the navigation. You can work really with this shaver also, or any suction instrument, like for example this curve suction. You can do it in a navigation.
Okay, thanks.
They have and also curve. They have curve one for probing the area of the frontal sinus. If you want, they have just this part. You can connect it with any instrument you work with, or they give you the sensor of navigation. Okay. We will continue the removing the unsnip. Then there's a area here, the unsnip. This area we again remove by bud biting here to increase the size of the ostium. Here, as you see, you see.
Yeah.
You remove this area and increase the size of the maxillary ostium. Then we can use a shaver instrument to remove this hole inside the maxillary. Okay. After remove the lower part of the uncinate, we will remove the remaining part of the upper part of the uncinate.
Dr. Hemant, we can use the navigation system in some of the steps for the audience.
Yeah, okay. Yeah. Just to remove the uncinate, then we show you the sigmoidal molar by navigation. And we make the uncinate anteriorly to remove by either Harrison or Sucas portion. And you can use the shaver also to remove the ruminant part of the uncinate. You see? You see? Yeah. I usually use either Sucas or this one is Harrison portion. To remove the uncinate. And the remaining can remove by shaver instrument. As you know, most of the case, uncinate is attached to the lamina papyrus. This is the ethmoidal vulva, you see. The preparation of the case, fortunately, is very good. So she prepared the case well. Here's the ethmoidal vulva, as you see here. It's a ethmoidal vulva. I will show you by navigation also. This one, ethmoidal vulva. As you see in the imaging also, we are in the, on the anterior part. This one. Do you see the navigation?
Yes.
Yeah. Here is the ethmoidal vulva. Here is the retrobulbar space. Here. Here is the retrobulbar space. You see? And this is the basal lamella of the middle pelvis. Here. You see? You see here?
Yes.
Usually, we open the ethmoidal vulva inferior here, from the noun area to the unknown. Usually, you will enter the, yeah, as you see, we open the ethmoidal vulva here, and then we cross this area, this removed part, by the patient, then we use shaver because there's a hard bone, you see, we use a keratin everywhere. We use a keratin everywhere to make bone and mucosa, make it a mucosal soup, like a soup. As you see, then we use a shaver, microdivider, for removal of this part. As you see, yeah. The beauty of keratin give you a guide also, like a seeker, give you a guide where is the space. If there is no space, the keratin does not go inside. You see? This is a very safe instrument. Very safe instrument. And use usually we use the microdivider to remove the edge, not remove the mucosa, usually. Not shaving inside the cell, usually the ridge. We run the ridge. Usually we run the ridge. Now we demonstrate the next step. As you see here, the basal lamella, which is the second part, here is the vertical part, first part of the middle tegment. Here is the second part of the middle tegment that's attached to the lamina papyracea. As you see here, this is the basal lamella. You see, adenoid ruminant.
Among the audience, do you have any questions?
the basal lamella. We usually this one a basal lamella. Vertical part is the first part of the middle terminus. This is the second part that's oblique attached to the lamina papyracea. We usually open inferior here. And third part of the middle terminus, you see. This is the third part, this one, attachment of the middle terminus. Usually the blood supply comes from this third part that's attached to the near the sphenopalatine artery.
Dr. Heman, can you
Use navigation to show us the lamella and lamina.
This one, a basal lamella. Basal lamella. Basal lamella, this one. You see laterally basal lamella, well, attached. This one, laterally attached to the lamina papyracea. You see here?
Yes, it's clear.
Usually, we open the basal lamella inferior here to prevent the injury to the lamina papyracea and the optic nerve here. If you open here, you may make the orbit or orbital contact at rest. You should open here. This is very important. You should open here. If you open here, you are going to the posterior ethmoid and to the posterior ethmoid and to the superior method. Usually, if you open here, you face the superior terminus. Okay? Shall we open? You can do opening of this area by any instrument, any sharp instrument, or T-Rex, suction, saver, any kind.
Dr. Heman,
Bale.
I have a question about shaver.
Bale.
Can we connect this sensor with the shaver?
The sensor with the shaver?
Yeah.
Yeah, we can.
As you know that the shaver is very sharp instrument. Which level? Which view?
Now the navigation is connected to the shaver.
Dr. Heman, have you hear me?
Yeah.
Okay, if you complete.
You see?
Yeah.
This is a polypodal chain for the inferior terminus. Now we open this area, we can do by shaver.
Okay, thank you. Dr. Heman, which view is most dependable?
You see?
Was the land?
You see where we are in the the
I mean the view.
blade zero for 4 millimeter 11 here. This is a Mitronic table. As you see here, this is the superior table. You see, usually I am going to open the sphenoid sinus. Then after, I am coming from the anterior to the sphenoid sinus. Then after, from the posterior to anterior, we open from the sphenoid sinus, posterior ethmoid, and then to the frontal sinus. Okay?
Dr. Hammond, here's a question from Said regarding biology, which will depend on if you allow me, I will answer Dr. Said.
Yeah.
On all three, we need to have axial, coronal, and sagittal all together. And it's clear here for navigation also, we have all the three views.
As you see, we also use the Kelsen to remove this area. See? Yeah, there is a space, there is a cell here. You remove the posterior. This is a posterior ethmoidal cell. This is a posterior ethmoidal cell. You see? It's very safe. You go inside and bite. As you see here, you go inside and bite. It's also like a seeker, also showing you that where's the space. Here's the space. You can't even space. Here's the space. Here's the space. Here. You see? You make the mucosa like a tube. As you see here, there's a posterior ethmoid. And then we use a shaver instrument. It's a posterior ethmoid. You see the cell in the navigation? You see?
Yes. Yes.
Yeah. Usually the level of natural sphenoid ostium here. You see, medial to the superior tendon. We don't remove the. Usually, superior wall of the maxilla is a very good guide, for the magnetic ostium. Usually, if you see anything above this level here, for example, this is not a sphenoid. Usually, you are going to medial here, usually here. It's a natural ostium. You see here, the natural ostium here. Is it clear?
Yes.
Yes.
Can you pause
Yeah,
by
we remove this area by two cut instruments. Then we enlarge the ostium, the natural ostium. As you see here, usually it's medial. This is a standard. There's no variation. Usually, the natural ostium is medial to the superior tegmen. You see the superior tegmen here. You see? It's a superior tegmen. It's a very good landmark here. Guide you to the sphenoid ostium. You see here? Yeah. We are going to remove the anterior part of the superior tegmen. We remove the anterior part of the superior tegmen. And then we use the microdebrider navigation, you see this one, the posterior node, this one. You see, it's the onodi cell here. Here is the, you see, we are inside the sphenoid sinus. You see?
Yes.
Is it clear? Yeah.
Yeah, it's clear.
We can remove this partition here between the onodi and the sphenoid sinus. Yeah. Visually, this, you see, here is the, we can enlarge this area. You can enlarge this area by tracing, and we open this area also by tracing. And this way, yeah, and this area also. I will show you the carotid artery and the optic nerve.
To him and have you me?
Yeah.
Yeah.
Yes, okay.
Yeah. I have a question about the posterior point.
Yeah.
Would you mind to tell us the level of the posterior point diaphragm and show us by navigator system?
Not good. Yeah, this is shaver effect. Here is the maxilla, you can see all of the maxilla. You see? Here is the posterior, this one.
Yeah. At the roof of the antrum view.
Yeah, you see here the root of the maxilla, and here is the,
Yeah.
you see the root of the maxilla, so there's a little receptor here.
Yeah, it's here.
Yeah, here. We enter in the instrumentation inside the spinal because, as you know, there may be dehiscence of the aortic and carotid canal. Sometimes you may inject line instrumentation. You see here,
Yeah, it's here.
you can remove the weight also. You can remove the weight by super instrument. And here is the only cell. Here is the only cell. The optic nerve inside. Let's remove this weight. Then I will show you the optic nerve. This is the carotid. This is the carotid. You see?
Yeah, yeah.
Yeah, this is the carotid. This is the carotid artery. But the optic nerve inside the, yeah, here is the optic nerve.
Yeah,
Inside the onodi. If you have
Have you-
onodi, important of onodi, when you have onodi, the optic nerve is inside the onodi.
Yeah.
Carotid, you see here the carotid. There's the opticocarotid research here. You see?
Yeah. Dr. Heyman,
Okay?
have you heard me, Dr. Heyman?
Yeah.
So I have a question about the navigator system is very important to
Yes, I will show you. I will show you.
to appropriate the side of the onodi cell.
Yeah. Here is the sphenoid, we are inside the sphenoid, is the carotid artery. I don't know if it's here or not. This is the carotid artery. Here is the carotid artery. I think, upside down. Yeah, straight. Because sometimes antenna will not show you. Yeah, here is the carotid artery. Here is the carotid artery. Behind this circle. Here is the optic nerve.
So the only all of this inner view, I mean radiological.
Yeah, this is the inner view, and this is the optic nerve here at the corner. You see in the navigation?
Yeah.
Corner.
Now it's, thank you.
Telefon gibi telefon. Now we remove this part and this part of the septum of the maxillary of the posterior nerve, as you see here, and see a part of the nerve. We identify the optic nerve. Now, here is the, I think here is the lamina separation. Also, just to verify the case. The skeleton is very good instrument. And very good. The science says that you know all the landmarks, the surgery is landmarks. You see, fortunately, our case and surgery and preparation is very good. Anatomy is very good.
Dr. Naaman, I have a question. So this patient is for demonstration,
Yeah.
but I know you did a lot of endoscopic surgeries. So in such a patient, do you use a navigation system or it's not necessary?
No, not necessary, I think. For me, it's not necessary. Depend on the person. I don't use that navigation for the primary. It's beneficial for longitudinal case and for the tumor case. As because one for in the lecture. This is the very good tool, but you should know the anatomy. Anatomy of the sinus is very important than even than navigation. Because sometimes you may make a mistake even you have navigation. Usually I use the shaver to run the ridge. You see, it's a ridge. You run the ridge. Yeah, that's called removal of the inside the cell. Now we finish the posterior part. We finish the posterior part, the sphenoid, the node. Then we come to the anterior, from posterior to anterior. The survey usually you can't do the opening of the frontal sinus through intraocular technique. Before removing the bulla, you can't go inside the frontal recess. But I usually adapt to make the dissection of the skull base, then we open the sphenoid sinus.
Question and comment? No?
You see, here is the onori, this is spino, carotic viscous, here is the viscous, you see?
Yeah, yes.
Viscous.
There is a question. Have you hear me?
Yeah,
Among audience, there is a question.
yeah.
Okay.
Thanks, Mr. You are doing nice operation.
Thank you. Thank you.
The most important thing that our time is limited, and your operation make a long operation. So
I don't need it.
Have you get question?
I don't, can you make a loud sound?
Thank
Can
you.
it?
Okay.
Can it?
Dr. Sulaiman,
Yeah,
please.
very good.
do you hear me now?
Yeah, I hear.
I mean that our time is limited, and your operation is a big operation, meaning many hours. The most important thing for us that show us technical points related to navigation, for us because the time is limited for us, maybe not use all time.
I will try because you have to demonstrate the one side. I will complete one side. Then I will finish the live demo.
Okay, but what your plan about anyway?
What?
Anyway, this big anyway, large anyway, has this age gets old, and last what is your plan to do for them?
Victor, please ask about the edging.
Yeah, I will do attenuation by call later. I will do by call later on.
Do you take biopsy?
No need for biopsy. It's the case of LAD. There is no mass in the. There is no mass leaving. If you want to see, it's like a polypoidal thing.
Okay, thank you.
Dr. Heyman,
Over the case,
have you finished or not?
yeah.
Dr.
No,
Heyman,
I'm not finished. Yeah. If you want.
are you listening? Dr. Heyman, have you heard me?
Yeah.
For remove adenoids, using the shaper or not?
You can use the shaver, but I want to remove by ablation.
Okay. Clear?
This is,
Okay, thank you. So what is your objective, Dr. Heyman?
now I'm
You
going
will-
to remove the adenine cell here. You see?
Okay. Yeah.
I want to remove this area also. You see? It's a skull.
The anatomy is a bit not clear.
Yeah, okay, I will show you now.
Okay. Where is the microcarpinate?
Yeah, this is a middle kidney. I'm going to inside. Yeah, this is skull base. You see? Here's the ulnogy, this is spinal.
Okay.
Here's the skull base. I will remove this ridge by through-cut process. The through-cutting instrument has advantage on the blind instrument because if you have, for example, in this rig you have anterior ethmoidal artery. You cut it like this, the artery does not go inside the organ. You see? I'm sure there is no anterior ethmoidal artery here, but I want just to demonstrate. Yeah.
The anatomy of anterior ethmoidal.
I will show you.
Okay.
I will show you. But just I want to demonstrate the beauty of through-cutting instrument. You remove the ridge. If there is a bleeding inside, you can cauterize easily. Yeah. means it's very important. Then you come to removal of the card by shaver instrument. It's a remnant of severe table, this one. Here is still, you see, usually I am a little bit aggressive in the sinus surgery, but I want to open all the sinuses to I will change my scope to 70 degrees. I want to come because one to nice preparation of the operation theater. Really, we spend a lot of time to prepare this event.
Do you have any?
Here is the 70 degree scope, and this one is 120 blade shaver. Usually I use for the swimming or for the frontal sinus, I use this nice shaver instrument, 3.5 mm, 120 degree shaver. This belongs to electronic company, very good. Usually I use the angle instrument, 70 degree scope. You want, I will show you. Yeah, we can actually. Yeah. I will demonstrate for you the frontal sinus seeker with the navigation. You know the frontal recess where it's located. Yeah. There is Agernalissa. You see Agernalissa.
No, it's not good.
That clear?
Yeah.
Clear? It's a Agernalissa. We open.
Have you the
Usually because here the enzymatic process attached to the lamina fabrica. Usually we are going to medial to the enzymatic process, and we open the frontal recess here.
Yeah.
Now I will show you. Now I will do calibration.
So you want to do calculation internally?
Yeah, usually you do calibration for any instrument you use. Now the technician is with me.
What?
They will do calibration of any kind of instrument you want.
Calculation.
He's a technician of the company. He's with me.
You mean the calculation? to tell us the facial anatomy of
Yeah.
calibration.
Yeah. There's an antenna here. There's a calibration, and then you don't know. You see the navigation. This receives the wave antenna here, and there is
Dr. Herman,
yeah. Well,
about the calibration. Calibration means show us the facial anatomy.
we have many. This one. You see this one? This one is the probe of the company. This one
Yeah.
we use for just examination. If I want forward, there's an antenna here.
Have you heard me, Dr. Herman?
Yeah, I hear you. There's an antenna, we connect it to the, for example, in this frontal sinus seeker, we connected the antenna with the frontal sinus seeker. You see? You
Okay.
see? You see in
Yeah.
the camera,
Yeah,
It's clear?
yeah.
We make it diagram to show you the navigation, where we are exactly. Okay?
Dr. Hemant,
Well,
when it use animals, it will attach the antenna and they will do calibration.
They
for
will,
each.
they will do calibration. We can use
Yeah, for it.
here is a standard of the navigation. They will calibrate like that. They put on the side and they will calibrate. Okay? If you see, I'm going inside. A little bit. Here is the other navigation. You see, other navigation. 70 degrees scope. We are going medial here, out fracturing. You see?
Dr. Herman, a bit unclear.
Unclear? Okay.
Yeah.
I will make. Okay. No. Do you see the scope here? Do you see the scope?
Yes.
This is again as this cell. Now this is the prominent of the instrument. Usually we out fracture this one to identify that, you see, this is the frontal sinus recess. You see? The recess.
Yeah.
This one is recess.
Yes.
Yeah. It's again, here is the other nerve cell. There's a cell on the frontal recess. If you want to clear, you should remove this cell. Okay? And we have a very nice instrument to make enlargement of the. Now we are going inside the frontal sign. Okay. Now we have angle. You see this angle shaver. You see, you can clarify for you. Yeah, this one. You can't remove this time. This ridge.
So do you want to do the cell?
Yeah, we will remove the cell.
Okay.
Yeah. There's a very nice tool that is belongs to the source company. You see, it's a Hofmann punch, like that. Hofmann punch, this one. It's very good. It's curved 3.5 mm, curved mushroom, like a mushroom. But the difference from the mushroom, this has a circular circular end. You see? Is it clear now on the spot?
Yeah, it's me.
Now, this is work like that. Sorry for, there's a shadow, you cannot see the movement. If you show me on the camera, yeah.
What's the
Focus, please. Move like that.
يدرون كم يدرون
It's
كم
a
يدرون كم
Haussmann fund.
إيه
Now
Focus.
Haussmann fund is very good for enlarging the sphenoid recess. Do you see? Do you see?
Yes.
Yeah. Yeah, I usually use this instrument to enlarge
برودس برودس
the recess. You see?
يدرون كم يدرون كم يدرون كم
Yes. I'm going to remove this ridge.
يدرون كم
You see?
إيه ريدة بس
Yeah.
The tip,
They
the
keep
tip.
going inside. They keep going inside the sinus.
Okay.
And the cutting area make the ridge inside the cutting area. You see?
The tip is not clear. يعني.
Tip?
The tip is
We
remedied.
are going inside the frontal
Okay.
sinus by the tip.
I mean alongside with the endoscopic, not clear.
Yeah, I will show you now. Now this okay. Less than 5 minutes, I will finish the demonstration.
So any from the audience?
Now I open the frontal recess here. I will show you now. Just to make it more facet. The frontal recess.
Just
Strawberries. Look at the
Yes.
strawberries. You see? Here's the strawberries.
Dr. Heyman,
Well, tell me.
if you just attach the instrument and show us the inside of the sinus, here and from
Yeah, okay. I will show you. Okay. Okay. Now you see, we are in there. Let's remove the so you see, I am inside the frontal sinus. Is it clear in the navigation?
yes, it's good.
Clear. You see, I'm inside the frontal. About
Dr. Heyman, thank you very for this.
Do you have
Yes.
any question? Do you have any question from the audience?
Any question?
Nobody? Usually I do this I do the in all cases of sinus surgery I will do like that. I will open the frontal sinus, the ethmoidal, even there is no pathology.
Dr. Heyman,
This is a full house case.
Last
It's a
question.
full house.
Question.
I have some, yeah, okay.
can you show us the supraorbital clear now or not clear? That's,
I think there is no supraorbital here in this case.
oh, no.
No supraorbital. There is no supraorbital here.
Okay, thank you. Also, there is another question.
Yeah.
Audience,
Question?
have you heard me? Dr. Heyman, have you heard me?
Yeah, I
Among audience, question, he asked about the cost of this system, navigator system, I mean, for the patient.
sorry, I don't get.
Can you tell us the cost of the navigator patient?
The sound is not coming well.
Cost.
Cost.
Have
I
you heard me?
don't know. You can ask the third one. Yeah, you can ask the third one.
Okay, thank you, Dr. Heyman. Very nice.
Regarding the postoperative care, is very important in the sinus surgery, you know.
Okay.
Usually, we use the topical irrigation mixed with the steroid. We have in the market Palmicor, which is budesonide solution. We add one each time inside the, or the patient has cannot take it because it may be costly for the long period use. You can use mometazone cream, not ointment. Cream can be mixed with the saline. We have a saline irrigation that we usually use from our company. We have three nasal irrigation. They have 240, I think, ml bottle. We add tap water and their salt. There will be isotonic solution, and then add the steroid inside for the irrigation to freeze the steroid inside the sinuses. We usually prescribe for those patients want to look as well. I took a biopsy just for eosinophilic count. For example, in those cases, they are high eosinophilic count, like for example 100 or more than 50, 55. More than 55, usually recurrence is very high. That's why there's nowadays the biological agent, dopilumab, is very useful in those patients. If you clear the sinuses, they will help you.
Thank you very much, Dr. Heyman. Thank you very much for your nice presentation. Thank you.
Thank you so much. Thank you so much.
Big appreciate